I met Ted Smith when I showed up for work one night in the intensive care unit. He's an older gentleman, mid-50s, reasonably healthy other than a little obesity and diabetes. He'd fallen into the intensive care unit, though, because of septic shock, a life-threatening infection that throws the body entirely out of the balance required to maintain health. I discovered from the day team as we were making our rounds that they weren't sure what the cause of Ted's septic shock was. When we have a diagnostic puzzle like that, I do a very thorough examination to make sure we haven't missed something. And particularly in a diabetic, I want to make sure we have not missed a life-threatening infection of the genitalia. And I asked, did you rule out Fournier's gangrene, our complicated name for that condition? And a bright, enthusiastic young resident said, oh no, we didn't, and immediately grabbed Ted by the scrotum and began to inspect his genitalia. Not a word to Ted that this was about to happen. Now, in the event, Ted appeared to be unconscious, and so it felt like it was a normal kind of thing you would do in the intensive care unit. I was angry and frustrated because we've been trying to stop this kind of behavior in the ICU, but as I pulled out my tongue to lash the resident, I was also ashamed because I realized that when I was his age, I did the exact same thing. We work in a marvelous place, we clinicians, but we also do terrible things by accident. What do you lose when you become a patient? You're stripped into this bizarre, I have no idea why this exists or what it's meant for, but you're stripped naked and stuck into an ugly outfit and then manhandled. You lose your name. You very rapidly become room 503, the appendectomy. Where else do you lose your name, your clothing, and your dignity? Prison. Increasing studies are suggesting that people who experience dehumanization, even in a medical environment, suffer psychologically. There's even an interesting study from a couple of decades ago suggesting that people suffer physically from the dehumanization routinely practiced upon them in a medical environment. Why would this be? Why would good people who wake up every morning with a desire to make the world a better place actively dehumanize the vulnerable people they are called to care for? There are several important and compelling reasons. The first is that being a clinician is hard intellectual work. We have to figure out what's wrong with a person. We have to memorize 1 million different physiological details and figure out how to take that theoretical knowledge from medical school and make it real in the life of an individual person. Imagine those of you who are not clinicians being asked to do a calculus problem in your head while the person you love most in the world sobs beside you. It's very difficult to do complicated analytical thinking while you're exquisitely aware of the humanity of the person on whose behalf you are thinking. There's another reason, though, particularly in the intensive care unit, why we might dehumanize individuals against our better judgment. And that's because, on average, about 1 out of 8 of the patients we treat will die within the month. Think about that for a minute. If at your work, 1 out of 8 of the people you interacted with or took care of died every month. So part of the reason that we dehumanize as clinicians is so that we can come back another day and bless the lives of other people. There will always be tension as we work to humanize the people that we are taking care of. That tension will not go away. It's also not specific to medicine. Dehumanization as a psychological construct comes out of studies of the 20th century genocides. How is it possible that good-hearted, thoughtful, kind, civic-minded Germans in the 1930s decided that it was a good idea to believe that Jews, gays, gypsies, and disabled people needed to be murdered? We shouldn't kid ourselves. In this room, I suspect that 80% of us would have been Nazis if we were Germans in the 1930s. Dehumanization matters in broader society in these catastrophic circumstances. But we all engage in a little bit of dehumanization, even when we haven't ended up in a corrupt, despotic regime. Think about the last time you struggled to understand how someone could oppose your favorite sports team. And think for a minute about your beliefs about the complexity of the mental lives of the people who dare to root for the New England Patriots, or who dare to care about the Yankees. Dehumanization happens ubiquitously, often at a relatively minor level. Hopefully nobody's killing someone else over a dispute about a sporting contest, but also at more significant levels. And to be honest with you, this 2016 presidential election really draws out the dehumanizing impulse in all of us in spades. The social psychologists that study dehumanization say human beings tend to dehumanize in one of two broad ways. The first is to deny to the person higher human emotional and cognitive faculties, to see this individual as more like an animal than a human being. You just need to see how people talk about Donald Trump to know immediately that he is routinely dehumanized as an animal, wild, unpredictable, out of control, lashing out like a wolverine. The other kind, though, denies to the recipient of the dehumanization even animal-level emotions like fear or hunger or arousal. Look at any Twitter feed critical of Secretary Clinton, and you'll see dehumanization of the mechanistic or robotic. People describe Secretary Clinton as Machiavellian, calculating, aloof, cold, robotic. Those are the two mechanisms of dehumanization that are ubiquitous even in relatively minor things like discussions about politicians. I've been talking a lot about dehumanization, but implicitly we need to understand a little bit more about what a human is. And here we're in a little bit of a pickle for the last 200 years. We're not entirely sure as a community or a culture what exactly a human being is. Back in olden times, we were the most important creature made by God. Perhaps we were even God's own children. More recently, we are the most sophisticated of the mammals. Some people think maybe we're both. Others wonder whether we're either. The social psychologists, as a way to solve, without solving, these difficult problems of definition, have said a human being is someone who has a rich mental life just like us. A rich mental life. But what do we do in the intensive care unit or other painful or difficult settings where the patient may not at that moment have a rich mental life? There aren't simple, quick solutions. They'll take a lot of work for us to understand the best ways forward. But as I've been researching this, as I've been treating patients in the intensive care unit, as I've had long discussions with our patient and family advisors in our Patient Family Advisory Council here at IMC, and as I've been the husband of a patient, I've come to see that there are simple things that we can do to bring the humanity of our patients back today. The way I think about the basics is what I call the dinner party rule. Say you've been invited to a dinner party, you respect the host, and you would like to impress them. Now, as a clinician entering the room or the space of a patient, you apply the dinner party rule. At a dinner party, you knock before you enter a room. And just like you would not, unless you're a criminal or really troubled, walk into the bedroom of a host unannounced, at a dinner party, you should not walk unannounced into the room of a patient. Knock before you enter. Going to a dinner party, you would not say to the host, when you know perfectly well that he goes by Neil and has his entire life, Cornelius? Cornelius? You would say, if you didn't know him very well, Mr. Smith, it's good to see you. What would you prefer I call you? Think about being in the waiting room of an outpatient clinic. How often tone-deaf legal first name is loudly announced instead of saying, Ms. Jones, hello, what name do you prefer I use with you? Part of how we identify ourselves in space and time is to have a name, and a name that matters to us. And often, it's not the name on our birth certificate, that faceless bureaucratic document that gets brought anew to life every time you're stuck in an outpatient waiting room at a hospital. You also, I pray, would not touch your host the way my resident touched Mr. Ted Smith. You better not. It's a reminder, though, that in medicine we sometimes have to do dumb, bad, or strange things, like grab a person by the genitals. But if we have to do those uncomfortable things, we need to ask permission. Mr. Smith, I'm sorry, I'll need to examine your genitals to make sure there's not a serious infection there. Is that okay? That acknowledgement, that's what you do to another human being. You do not assume they are just a bunch of organs and body parts. You assume they're a person with agency and an interest in the privacy of their own body. What about people in coma? What do we do with people who are in coma? That's very common in the intensive care unit. And it's hard. It's strange to talk to a sleeping person. But think about it. We talk to animals. And we talk to our technology. We say Siri or Alexa. We humanize stupid phones with screens and dogs and cats more than many of us humanize people who are in coma in the intensive care unit. My practice, and it's been the practice of many good clinicians over the years, even though some of us are inclined to forget it periodically, and I confess that I have often forgotten that over the course of my medical career, is to talk to them like they're awake. First, you never know whether they are awake. Some of them actually are listening. And second, it's a way to remind yourself and them that this is a human being. There are other simple things you can do. If we're worried about the humanity of a patient, who should we call? Who should we have be a part of our team? Well, ideally, you'd call the world expert. That's what we do when we get a really rare tumor. That's what we do when we have a really vexing clinical diagnostic problem. We call the experts. Who are the world experts in the humanity of our patients? It's the people they love and who love them. Let them in. We've pioneered here at Intermountain Medical Center the incorporation of loved ones into our life support procedures. Used to be they were thrown out, excluded. Now they're welcome. And we've been able to make them present with us. This, after a little bit of getting used to it, does not suddenly make the experience so vivid that we're unable to perform our technical task, but it makes sure that there's someone there who's truly expert in the humanity of the patient, looking out for them. In physical therapy, we have had active participation of family and therapists getting our patients up and out of bed and moving again. A patient whom we loved, they've given permission to use this photograph, and I noticed that her husband couldn't walk himself without a cane, but was so glad to be a part of his wife's recovery that he grabbed his cane in one hand and the ivy pole in the other, and off they went. And I explained to them why I wanted to take the photograph, and he said, yes, this is very important. But now you need to take another photo, because the most important thing I do is I love her. Relatively simple things to do, Invite the world expert in the humanity of your patient to be a part of the team. Those are the simple pieces. There are harder pieces. The research has not yet been done. We need to be very thoughtful that there is a tension that will never go away. If our clinicians are going to be able to do their job and not be so bereaved at the death of the patients they care for that they can't get out of bed in the morning, there will need to be a balance. They cannot see every patient they treat the way they see their life partner or their child. They cannot do it. No human being can suffer that degree of bereavement intact. So we've got to do something, though. And I've become increasingly persuaded that the right research strategy and the right early interventions that we can start thinking through carefully are in the realm of empathy. Now, empathy is a radically overused term right now that has come to mean I'm not even entirely sure what. So I wander back to its introduction to English. It comes into English at the hands of an art critic who said he wanted to understand how a work of art could draw the observer into it with a kind of passion. So he thought of empathy as feeling into a work of art. Think about it. Most of the time we sort of wander through the museums hoping we look great for wanting to go to a museum, and then periodically we see something and we feel our ways into it. And what I'm encouraging myself and others to do as we begin to think through the solutions is to imagine patients as works of art, rich and beautiful and multifaceted and fascinating. To make this concrete, I'll tell you the story of Beth. The nurse came to me one afternoon and said, "Sam, I think you need to talk to Beth. She's 80, but strong. She has a serious infection in her leg. She even has septic shock, life-threatening complication of infection. And she thinks maybe it's time for her to be done." This is not uncommon for an intensive care unit clinician to have to think about issues of life and death with their patients and to wonder, has the end of life truly come? I was prepared for a relatively straightforward conversation. Most 80-year-olds with septic shock who have raised the possibility that it's their time to go really do feel like their life has come to its natural end and would like to die a natural death. As I started talking and listening to Beth, it took about 3 or 4 minutes for me to realize that all was not going according to the traditional narrative. There was something different. So I listened for a few more minutes and then asked a few directed questions and realized that Beth was actually suicidally depressed over regrets at how she had mistreated her daughter through her life. We owned that together for a moment, understanding this new detail of this fascinating work of art that Beth was, and realized that in point of fact, Beth did not want hospice and to die. Beth wanted treatment for her depression and reconciliation with her daughter. That's what I mean by that empathy. And it's my conviction as we work through these hard questions that what is highest in us as human beings is our capacity to think and to care and to honor. Thank you.